Hello, welcome to Sonography Radiology Training Channel. This series of videos is about placental imaging. This is the 9th video in this video series with title of Placenta Accreta Part 1. The outline of this presentation include introduction, complications, risk factors of placenta accreta, ultrasound diagnosis, including sonographic findings of placenta accreta in grayscale ultrasound and also in color Doppler imaging, ruling out placenta accreta spectrum, and final teaching points. At first, introduction. The normal placenta attaches to the decidua and does not invade the myometrium. At delivery, the placenta separates at the decidual plane with an abrupt scission of intraplacental follow as the myometrium contracts. The pathologist differentiates placenta accreta spectrum into three subgroups. A placenta that is abnormally adherent to the uterine wall after delivery is termed placenta accreta. The term placenta accreta is used when the placenta invades the myometrium more deeply, and the placenta accreta refers to placenta that at least in part protrudes through the uterine serosa. Terminology has changed appreciably over the past decades, and placenta accreta spectrum is now thought to best represent this entity. The synonyms for this entity include abnormally invasive placenta, abnormally adherent and invasive placenta, and morbidly adherent placenta. If clinicians only employ a histopathological-based system to classify prenatal imaging, they are not fully utilizing the available science to inform clinical management and delivery. Therefore, prenatal imaging should not only attempt to diagnose presence of placenta accreta spectrum, but should also aim to predict clinically relevant findings, such as neovascularity, posterior bladder wall involvement, or cervical invasion, so that management, surgical or conservative, can be appropriately formulated in advanced therapy, reducing maternal morbidity at delivery. Complications of placenta accreta. Placenta accreta spectrum is a serious complication of pregnancy associated with maternal blood loss, need for hysterectomy, and retained products of conception. What is the risk factor of placenta accreta? Although placenta accreta spectrum can occur in any pregnancy, the most important risk factors include prior cesarean delivery, with risk increasing with increasing number of prior cesarean deliveries, and placenta previa. You can find full explanation about placenta previa in this video of this video series. Also, there are minor risk factors including multiple gestations, advanced maternal age, assisted reproduction or in vitro fertilization, prior uterine surgery including myomectomy, and operative hysteroscopy. A woman with no placenta previa and no prior history of cesarean delivery has a baseline risk of 0.26% for placenta accreta spectrum. This increases almost linearly with number of prior cesarean deliveries. All women found to have anterior low-lying or placenta previa should be asked if they have had a prior cesarean delivery during prenatal consultation, and if they do, they should be referred to a center with expertise in the prenatal diagnosis of placenta accreta disorders. It should be emphasized that placenta previa without previous damage to the lower segment of the uterus is very unlikely to be associated with a clinically significant placenta accreta. This ultrasound image from a 26-year-old woman in first pregnancy without any history of uterine surgery. We can see here the bladder, the cervix, internal os, and obvious placenta previa. But as you can see in this clip, we can't find any findings of placenta accreta spectrum in this patient. A myomectomy involving subserosal myomas that did not breach the cavity do not increase the woman's risk of clinically significant placenta accreta. Ultrasound diagnosis. Antenatal diagnosis is optimal so that delivery plans can be made prospectively, improving the outcome for mother and child, especially when cared for by experts in this disorder. Grayscale and color Doppler ultrasound are considered the primary diagnostic tools, with overall sensitivity about 82 to 100% and specificity about 71 to 100%. Multiple reported sonographic signs have been associated with Placenta Accreta Spectrum. Sonographic findings of Placenta Accreta in grayscale ultrasound. These findings include abnormal lacunae, loss of normal hypoechoic retroplacental myometrial interface or clear space, myometrial thinning less than 1 mm, disruption of the hyperechoic subvesicular uterine cerca, placental bulge, and the presence of focal exophytic masses. At first, abnormal lacunae. The presence of abnormal lacunae is the most important ultrasound sign of placenta accreta. Lacunae are multiple, large, irregular, anechoic areas noted within the placenta, give the placenta a mouse-eaten appearance. In severe placenta accreta, placental tissue is found more deeply within the myometrium than it should be, often passing the level of the spiral arteries and reaching the radial and arcuate vessels. This causes extensive dilation of these higher pressure arteries and massively increased velocity of flow into the delicate intervillous space. Also, these lacunae can sometimes be seen throughout the whole placenta because of the underlying pathophysiology. On careful inspection, they should be seen to be adjacent to the basal plate of the placenta. Placenta accreta related lacunae must not be confused with placental lakes or echogenic cystic lesions. You can find full explanation about placental cyst and sonolucensis in video 6 of this video series. Placental lakes are frequently confused with PAS-related lacunae, and the terms lake and lacunae are often incorrectly used interchangeably. On real-time grayscale imaging, lacunae and lakes appear as hypoechoic areas within the placenta. However, typical PAS-related lacunae are often irregularly ellipsoid in shape and extend from the placental bed, where they receive blood supply from the feeder vessels or deep myometrial vessels, that is, radial or arcuate arteries. Placental lakes often, but not always, contains slow-moving blood and are easily compressible with the ultrasound probe, whereas typical PAS-related lacunae are not compressible. It must be noted that lacunae and lakes can be present in the same PAS placenta. However, they should be differentiated based on their size and location. Also, PAS-related lacunae are often numerous in the region of the abnormal placentation, whereas lakes are usually few and widely distributed. Placental infarcts often present as hypoechoic regions with hyperechogenic rim, famous as echogenic cystic lesion, or well-circumscribed lesions with mixed echogenicity and are often associated with preeclampsia and fetal growth restriction. Placental infarcts can be differentiated from lakes and lacunae by the characteristic hyperechoic rim. Loss of normal hypoechoic retroplacental myometrial interface or clear space. The retroplacental hypoechoic zone is the sonolucent space between the placenta and endometrium. The absence of these signs indicates a loss or deficiency of Nitabuch's layer and the subsequent fusion of the placenta and myometrium. This can affect the whole placental surface or only a part of it, famous as focal placenta accreta spectrum. In this schematic view, we can see here the fibrinoid deposits which form the subchorionic Langhans layer. Here is Rohr's layer. Rohr's layer is found at the level of the basal plate beneath the stem villi. Lying still deeper in the decidua basalis, they form Nitabux layer. This is located at the boundary between the zona spongiosa and the zona compacta, where the release of the placenta takes place after delivery. This is currently the only known direct marker for placenta accreta. However, the specificity of this sign is an issue of controversy because of its susceptibility to false positive results. The retroplacental hypoechoic space is influenced by external compressive force, usually from passing heart with the ultrasound probe, as you can see in this clip. Due to susceptibility of the retroplacental hypoechoic zone to compressive effect, care must be taken to prevent or minimize the compressive effect of the probe when assessing the ultrasound bed for the presence of the clear zone. This sign becomes more prominent in advancing gestation because of myometrial thinning and prominent dilatation of the uteroplacental circulation. To have a clear assessment on ultrasound, the dynamic range, color Doppler, and focus must be used to improve contrast resolution and zoom feature to enlarge the image for through assessment. As we can see here, the loss of the hypoechoic zone, and here in a normal placenta, we can see obvious hypoechoic plane. Myometrial thinning less than 1 millimeter. Myometrial thickness less than 1 millimeter or an area of imperceptible myometrium behind the placenta has been reported as a sign of placenta accreta. Myometrial thinning has been attributed to the progressive migration or invasion of the extravillus trophoblast through the abnormally healed myometrium, resulting in minimal or absent myometrium to support the placental bed. In this case, any attempt to separate the placenta could result in torrential hemorrhage. However, data obtained do not establish a clear association between myometrial thickness and the severity of placenta accreta spectrum. Both myometrial thickness of more than 2 mm and abnormally thin myometrium have been reported in placenta accreta spectrum. To be clear, thinning of the lower uterine segment can be a normal finding in the third trimester and may be related to fetal presentation. This may be further emphasized after a previous cesarean delivery due to significant scar thinning resulting from poor myometrial healing. Occasionally, the placenta may overline an area of simple uterine scar dehiscence without any abnormal placentation. This phenomenon is known as a uterine window because the placenta can be seen through the lower segment at delivery. In this ultrasound image, we can see the bulge of the placenta, not the completely normal uterine tissue around the defect, and the lack of the signs of the placenta accreta spectrum on ultrasound. Even though this is not a placenta accreta spectrum, there is a significant risk of uterine rupture, so it must be approached with care. The presence or absence of additional sonographic and clinical markers of placenta accreta spectrum will differentiate between the two pathologies. Hence, when screening for placenta accreta spectrum, myometrial thickness should not be used as the sole parameter for diagnosis, but must be used in conjugation with other imaging signs. Disruption of the hyperechoic subvesicular uterine serosa. This is the loss or interruption to the bright line representing the bladder wall, or the hyperechoic line between the uterine serosa and the bladder lumen. This is potentially caused by villus invasion into the muscle of the posterior wall of the bladder, thereby changing the echogenicity, but is most often an ultrasound artifact arising from the massing neovascularity found between the posterior bladder wall and the anterior aspect of the uterus. Placental bulge. A placental bulge describes the outpatching of the uterus containing the placenta due to inadequate residual myometrium to maintain the structural integrity of the uterus. This image shows a obviously placental bulge, and here is a normal picture for comparison. This is an example of placental bulge on ultrasound and after delivery. As I explained, the bulge is caused by a loss of structural integrity in the muscle of the lower segment, causing it to bulge outwards. It becomes more pronounced after delivery as the upper segment contracts. This sign can be seen with both ultrasound and MRI and is highly predictive of Accreta or Accreta when used in combination with other imaging signs of Placenta Accreta Spectrum. If there is a bulge, the clinician can be confident that there is not enough residual muscle to contract and provide the living ligature required to stop bleeding from the placental bed. Therefore, forced removal of the placenta should not be attempted because it will result in bleeding. The presence of focal exophytic masses. This is defined as the deviation of the uterine serosa away from the expected plane caused by an abnormal bulge of the placental tissue into a night-bearing organ, typically the bladder. The uterine serosa appears intact, but the outline shape is distorted. It's most likely represent wireless invasion deep into and or through the myometrium, resulting in loss of structural integrity of the surrounding uterine muscle. Now, sonographic findings of Placenta Accreta Spectrum in color Doppler imaging. These findings include subplacental and or utero-vesical hypervascularity, bridging vessels, placental lacunae feeder vessels, 3D intraplacental hypervascularity. At first, subplacental and or utero-vesical hypervascularity. This can indicate the finding of extensive neovascularization within the peritoneum, especially between the anterior wall of the uterus and posterior wall of the bladder at laparotomy. This is the observation of a streaking or abnormally large amount of color Doppler signal seen in the placental bed or between the myometrium and the posterior wall of the bladder. In this image, we can see obvious subplacental hypervascularity, and this is a normal placenta for comparison. And this image shows utero-vesical hypervascularity, and this is a normal case. But here is a problem. It's a subjective decision by the operator and therefore requires experience with the normal placental beds, which are very vascular. This sign probably indicates numerous closely packed tortuous vessels in that region, demonstrating multidirectional flow and aliasing artifact. Care must be taken not to confuse conditions such as adenomyosis, which manifest as thick cystic and vascular myometrium from the neovascularization of the PAS, which is associated with an abnormally thin myometrium. In this ultrasound image, we can see the thick cystic vascular myometrium of a woman with proven adenomyosis at subsequent hysterectomy and a normal placenta. And this should not be mistaken for subplacental hypervascularity. Bridging vessels. These vessels appear to bridge from the placenta across the myometrium and beyond the serosa into the bladder or other organs, often running perpendicular to the myometrium. This bridging is an ultrasound artifact, as these vessels do not traverse between the myometrium and bladder but are actually the contorted vessels of the neovascularity within the peritoneum cut in cross-section in a two-dimensional image. It's sometimes referred to as equal sign running parallel to the uterine serosa and posterior bladder wall, and in some paper famous as rail sign. This is the sign often referred to as bladder wall interruption and is seen as bridging vessels within the color Doppler imaging. Placenta lacunae feeder vessels. Vessels with high velocity blood flow leading from the myometrium into the placental lacunae, causing turbulence upon entry. PAS-related lacunae can usually be confirmed by demonstrating high-velocity flow more than 10 cm per second with fetal vessels on Doppler interrogation, whereas legs sometimes show very low flow velocity for which the signals are rarely detected on Doppler but can be seen in grayscale imaging. 3D intraplacental hypervascularity. In 3D image, we can see complex irregular arrangement of numerous placental vessels exhibiting tortuous courses and varying calibers. In this 3D power Doppler ultrasound image, here we can see umbilical cord, placenta, decidual plate, intervillous circulation, and cotyledonal circulation. During serial examination, part of the intervillous circulation and abnormal lacunae merged together to develop a large aneurysm. This basal view showing numerous dilated vessels fused and extended to the whole placental bed. These coherent vessels, along with huge aneurysm, developed an extensively vascular complex over the serosabladder border. In another patient at 31 weeks gestation, 3D surface rendering depicted abnormal placental lacunae, as you can see here, and an exophytic placenta here. In 3D power Doppler image, we can see the new vascularization of this exophytic placenta also extended out of the uterine serosa and into the bladder. A small aneurysm was also found to connect with the serosabladder complex. Now, how we can ruling out Placenta Accreta Spectrum according to the ultrasound findings? The signs described so far demonstrate the uterine placental morphologic changes when there is abnormal placentation. However, lack of these signs does not definitely rule out all cases of Placenta Accreta Spectrum, as abnormal adherence has virtually no associated signs. However, to have clinically significant invasion, there should be some myometrial compromise. So a thick myometrium with no placental bulge is very unlikely to be seen in cases of increta or percreta. Currently, the only direct markers described in literature are the loss of the retroplacental hypoechoic zone. This marker is valuable for ruling out PAS but not for ruling it in. In simple words, the presence of the retroplacental hypoechoic zone excludes the presence of Placenta Accreta Spectrum in that area of the placental bed. However, care must be taken to develop sufficient experience to assess these signs and to examine the whole placental bed. In the next video, it will be explained about the important technical points that we need for accurate diagnosis. Now, please pay attention to these final teaching points. If on ultrasound scan a woman is seen to have a previa or anterior low-lying placenta, the operator should ask if she has had a previous cesarean delivery. If she has, this must prompt through examination of the placental bed for signs of Placenta Accreta Spectrum by the person with the most experience available. Consider tertiary referral or telemedicine if possible. Any concerns should prompt a request for a second opinion from a sonographer with expertise in diagnosing Placenta Accreta Spectrum. PAS is not a binary condition, it's a spectrum from abnormal adherence to severe percreta. Hence, the ultrasound appearance will significantly differ from case to case. The sonographer must therefore consider the underlying pathophysiology of the known ultrasound markers of Placenta Accreta Spectrum when screening high-risk patients and report on the clinical implications of all the signs seen. It should be emphasized that placenta previa without previous damage to the lower segment of the uterus is very unlikely to be associated with a clinically significant Placenta Accreta Spectrum. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.